Today's topic is ankle fractures. Good classifications that we utilize, or at least I do, is the Log-Hansen classification, as well as Weber, which is utilized more so by the orthopedic community. As we can clearly see, I'm going to try to zoom in onto the back part of this called posterior malleolus, which is the back part of this tibia of the ankle joint. Clearly we can see a separation. So there is a break. Now, typically with these conditions, we like to categorize them. If the fragment is greater than 25% of the surface area, then it requires fixation. If it's smaller than that, then you do not need to fixate it. It will heal on its own. So that is one break. We're going to go over these ankle fractures. The second break, as you guys can see, which is going downwards of the fibula, and a spike, as we can see in the gapping. We will see them further as well. Now, furthermore, you can see that as well here. So there is a little bit slight shortening, and there is gapping of the bone. So we're going to look at them as well. You can see a little bit of the bone should be further slightly down and more connected, as we can see. So in this situation, from looking at it from this angle, non-weight bearing views, they have some pros and cons upon the technician. So when we're looking at it from here, clearly we can see a gap. That would be basically a disruption of the ligaments, of the medial collateral ligaments of the inside of the ankle, and we can see a chip as well as a crack line. So obviously now we see three bone injuries of that ankle. We saw it on the outside, the fibula, we saw it on the rear of the tibia, and now we see it on the inside. So it's a trimalleolar fracture, and as we can see, there is a gapping as well as slight narrowing of the fibula. Now when we look at it closer, there's another line of fracture of the fibula. I apologize. We will see it clearer in other views. Upon rotation and manipulation, the ball does come back, the talus, I apologize, does come back into play. Now we can see the fragmentation, the comminution of that fibula, rather than just a spike and one oblique or spiral fracture that was seen on before. So we can see it's a couple of fragments of that fibula, which is the outside bone. So let's see what we did. That required 8 weeks of I apologize, 9 weeks of non-weight bearing, and let's see what the results are. So the patient refused to have surgery in this situation. I did opt for surgery because of the complexity of the phenomenon. But clearly, like I said in my previous lectures of the fifth metatarsal, the bones, the body, it does miraculous things. It knows what to do if it's allowed to do it. As we can see, the fuzz and the fuzz on the tip of that bone, that's called secondary intention or callus formation, which is bone healing. And we can see the blackness is actually in the line, the fracture line, which is the gap we saw before, is much, much less and more whiter, which is migration of the calcium phosphates. So that's good. The back part of the tibia is healed. And let's look at all these structures, if we may. So looking at it from this angle, it doesn't look bad at all. As we saw, the joint is fine. Everything looks great. We're going to rotate furthermore. We can see the gapping is much, much tighter. We can see the back part of it consolidating and anchoring itself. That's very good. And we can see the back part of this tibia, the posterior mal, we call it, which is barely can see the crack on top. And what else is there? So the alignment is there. Not much going on. The length is fine. Let's see what we've got. And what do we've got? Let's see. So looking at it from this angle, as we saw, the bone consolidated along the inside medial malleolus. As we saw, it was chipped and it was cracked and there was a gap. Now it's more consolidated and more uniform. The talus is back in its position, in its place, as we see, and as well as minimal gapping along the side. Yes, slightly shorter, but again, believe it or not, bones do grow over a year period. And this individual is an older individual. She's very, very happy with the results that we have achieved with a cast immobilization rather than surgical intervention. So there are things to be said about cast immobilization. Like I've told you before, heavy on the cast immobilization. I'm a great believer in immobilizing the patients with the type of casting that I've also left videos on. However, this individual, I opted and told the patient that would benefit from surgery. The patient did decline, and so she did heal very well. So that is, but again, not every patient is the same. This patient took it upon herself to stay in a wheelchair. Her husband wheeled her around, and she is also not young. She's, I think, about 70 years of age, and healed phenomenal. But again, she took it upon herself very seriously, to the letter, allowing the bone to bridge, and heal the way it should. So again, this was a fracture, as we saw right there, and we continued further downwards into this area. Everything is healed very well. The space is nice. The joints are optimal. There is no pain upon motion. Everything seemed to heal very, very well. So it's a nice case study in regards to trimalleolar fracture, which is unheard of in the literature, typically requires surgical intervention, and which I did opt to perform. However, the patient declined, and so was advised also to get opinions, second opinions, and she did seek orthopedics that were older in the profession, who ironically suggested cast immobilization. And so we went with that, and as per patient's wishes, she did heal very, very well. And even though she understood the risks and the complications from such decision making. But it's interesting that ankle fractures healing with cast immobilization, I've got dozens of these, not to that severity, however, to some extent, usually fibular fractures, which is the outside bone fractures, and heal very, very nicely without the plates and the screws and the lag screw phenomenon. A lag screw is basically a screw that goes along the fracture site on a perpendicular to obtain compression, and then followed by a neutralizing plate to neutralize the forces off the lag screw. And so that's basically what I do, as well as other foot and ankle surgeons and orthopedic surgeons. And in this situation, immobilization showed us that it can heal as well. Thank you very much. I hope this is helpful.